The presentation tonight is going to be on special deliveries, caring for the high-risk moms and also their newborns. And it's going to be a little bit of a tag team back and forth among the speakers. A really thoughtful presentation going from the history down to present day.
Our first speaker, and as Joanne said, they're going to alternate back and forth, but Tom Benedetti is he's really an icon of education and clinical care here at the medical school. He's a professor and vice chair of the Department of Obstetrics and Gynecology here at the medical school. He's a research affiliate at the University of Washington Center on Human Development and Disability, and the associate director of our simulation group, which is the Institute for Simulation and Interprofessional Studies, or ISIS. He's a really local boy done good and has hung in there these years after a brief sojourn to Southern California, where he did his residency in obstetrics and gynecology. And down there he learned to love deep sea fishing in the Pacific. And this guy can catch a slippery baby as well as a 25-pound king salmon. He's got this king salmon in one hand and his beautiful granddaughter Zoe in the other, both with a very firm, stable grip so they don't hit the floor. He did his fellowship in maternal and fetal medicine at the University of Southern California, Los Angeles, and also a master's degree here at the University of Washington in health administration. His chief clinical interest is in birth trauma and injuries sustained by the infant at the time of delivery. And he serves on the editorial board for the Society for Simulation in Healthcare, and he's also the chair of Patient Safety and Quality Committee at the Institute for Simulation and Interprofessional Studies. And here he is again with his, probably one of his larger catches, a 100-pound tuna caught off west of Cabo San Lucas. So he is really a guy with strong hands. He's the guy you need catching that baby in the middle of the night, not only doing that himself, but making sure that generations of obstetrics physicians are going to do it right for many decades to come. So it's a real privilege to introduce Tom, who's lectured and published widely on a whole variety of subjects and presented at many simulation conferences and universities around the whole country. So the other presenter, Joanne?
Once Dr. Benedetti catches the baby, if they're premature, he turns them over to Dr. Christine Gleason. She is the Allen Hodson Endowed Chair in Pediatrics, and she's a professor of pediatrics. She's actually chief of neonatology here at the UW Medical Center and Seattle Children's Hospital. For those of you that don't know what neonatology is, they will be describing it this evening. She is an affiliate research investigator at the University of Washington Center on Human Development and Disability. She also is a member of the Seattle Children's Research Institute Center on Integrative Brain Research. Historically, she obtained her medical degree from University of Rochester. She then moved to Case Western, where she received her residency in pediatrics, a neonatology fellowship. She is recognized locally, nationally, and internationally. This shows you a little bit of the local recognition. Seattle's top doctor, Seattle Metropolitan Magazine, and Seattle Magazine. At a national level, she actually was on the board of directors for the American Board of Pediatrics. Her chief research interest lies in the effect of medications that we give to these young neonates, the effect of drugs such as cocaine and alcohol. And if you think about these young babies in the intensive care unit, they may be suffering from pain, stress. One of her current research interests is studying the effects of morphine that's given to these babies to try and help ease their pain and discomfort. She's a storyteller. She recently published a book entitled Almost Home: Stories of Hope and the Human Spirit in the Neonatal ICU. And you'll be able to tell this evening that she really is a storyteller. Some of the reviews describe this book as an engaging, feel-good book about a remarkable woman's career in medicine and the exhilaration of saving young lives against almost impossible odds. And they'll show you pictures of these very, very small babies. Another review from Seattle Times described Dr. Gleason as a terrific storyteller. She is frank about her successes and shortcomings and deeply involved with her subject. And finally, Dr. Newland, who's been a professor at Yale and other institutions, stated the following. He says, "The neonatal ICU is a place of wondrous skill and deep compassion. It's largely because of the leadership of physicians like the remarkably gifted Christine Gleason. We are very lucky here in Seattle to have combinations of physicians like Dr. Benedicti and Dr. Gleason that can cover the whole spectrum of care, from the delivery to the care of the child." So join us in welcoming the two speakers.
What I'll do for the next 15 minutes is talk about the parallel advances that were going on in perinatology that mirrored the things that were going on in neonatology. I guess it's not exactly true. They got a head start, and they were doing a lot better and making us obstetricians look good because the babies were surviving much more often before we really got into the game to develop things. But the things that happened in perinatology were that we developed some tests to be able to tell how the baby was doing in utero. Before the 70s, none of this existed. Ultrasound was developed so we could look inside the uterus. We discovered how to give the mother a medication to actually speed up the development of the surfactant and reduce the risk of RDS. And then finally, we got a little smarter about twins. Before the advent of continuous electronic fetal monitoring, women in labor occasionally had the heartbeat of the baby monitored, and this slide shows the black dots, an occasional monitoring of the fetal heart rate, and a continuous reading then of the fetal heart rate from a small little wire applied to the baby's scalp. I was lucky enough to be trained in the place with the man that developed this technique, and it's been controversial. Some people aren't as convinced that it works as well as others, but it changed the face of obstetrics. And now, most, not all, but most patients in labor have the benefit of continuous or intermittently continuous electronic fetal monitoring. Well, what did we learn? Well, we learned, and again, by another man who helped train me, again, very lucky to be the place I was in Los Angeles in the mid-70s, that when the uterus contracted, when you continually monitored the fetal heart rate, babies that weren't getting enough oxygen had their heart rate slowed down. Well, suddenly, we could develop a test, we could give the mother some medication, make the uterus contract, and tell whether the baby was getting enough oxygen while it was staying in utero. But the question then was, well, what do you do with that information? About the same time, another man in San Diego developed a test to be able to assess the amount of surfactant in the amniotic fluid. It was called the LS ratio. So now, if we did this contraction stress test and saw that the baby was suffering because he wasn't getting enough oxygen, we could do an amniocentesis test and tell whether the baby would get RDS, whether it was born prematurely or not. And that changed everything, because now we had two tests to focus on the baby. And what were we trying to do? Well, we were trying to prevent stillbirth, or trying to prevent severe in utero damage that would result in a baby with lifelong handicaps. That developed the perinatal paradigm. And my colleague Zane Brown, who was the division head when I got here, said, it's better and easier to treat respiratory distress syndrome than it is to treat rigor mortis, which meant that if you found a baby that was starting to have trouble and you could deliver it, even if it would develop respiratory distress, that was better than risking the baby dying in utero, because there is nothing more devastating to the obstetrician or to the parents to have the baby die in utero while you're worrying and fretting. That paradigm that has been applied for the next 20 to 40 years has led to some unintended consequences that we'll talk about in a minute. The second thing that we developed was ultrasound. And this picture shows the abdomen of a baby and the umbilical cord insertion. This picture shows another baby with an abdomen, but there's all of this fuzzy stuff out there. And what is that fuzzy stuff? That fuzzy stuff is fetal bowel. This is called a gastroschisis, and it looks pretty terrible. But as it turns out, if we can diagnose this in utero, we monitor these babies very carefully. We deliver them at the appropriate time before the bowel gets damaged. We wrap the baby in a little baggie. I give it to my colleague, Dr. Gleason. They transport the baby to the children's hospital, where the bowel is reintroduced into the abdomen. Sometimes it can be put right in, sometimes it takes a little time before it goes back in. The surgeons create a neoumbilicus, and voila, at 6 months of age, you can tell that nothing happened. So this was one of the great advances then of ultrasound, where we started to be able to look inside the uterus, detect babies with problems, and time their deliveries so that all the specialists they needed could be around. This is an image of the fetal kidneys. The kidneys are here, little beans. This is the spine. The kidneys have collecting systems that usually have a little bit of urine in them. They're seen here to be dark. Sometimes those collecting systems are swollen. That often means there's some blockage someplace. In this particular baby, if you look into the bladder, there is a flap in the bladder that is preventing the urine from getting into the bladder sufficiently, and the kidneys are a little swollen up. It's important to diagnose this ahead of time, because when the babies are born with these kind of conditions, they don't come out waving their arm and saying, oh, by the way, I have an obstructed ureter. They usually go home and then oftentimes get a kidney infection. And sometimes those kidney infections can be absolutely devastating, where they develop kidney failure and even die. So now, with these screening techniques, which we can do during pregnancy, we can pick up these babies that have these problems and get them treated so they don't go home to unsuspecting parents and have problems. We also found out that we could give the mother a steroid, a drug like prednisone, which you all, many of you I'm sure, are familiar with. It goes across the placenta, and it stimulates the fetal lung to make more surfactant, oftentimes before it was ready. And so in 1972, the Liggins and Howie did some initial studies and showed that babies whose mothers had got these drugs actually developed less respiratory distress syndrome. But 1972, we were just coming out of the DES era, diethylstilbestrol. Well-meaning obstetricians gave these drugs to mothers to prevent miscarriage, and what did we get? We got female infants with clear cell carcinoma of the vagina and reproductive tract problems that made it very difficult for them to have babies. So obstetricians were very reluctant to start using this drug because we didn't have any long-term outcomes. Well, it took almost 20 years before more and more studies started to become overwhelming to show that we should be using these medications. And finally, in 1985, the NIH had a big consensus conference and basically said, hey, everybody, we got to use these drugs because they're the right thing to do. The safety data is now there. And now the administration of these drugs to women in premature labor who are going to be giving birth prematurely is a quality indicator that is monitored in nearly all hospitals. It takes a long time sometimes for advances to reach their way into the public arena and have all doctors apply them. And these drugs clearly increase survival, they decrease the incidence and severity of that intracranial hemorrhage, and they decrease the frequency and severity of respiratory distress syndrome. And finally, we got a little better at understanding twins. So I'm going to do Twins 101 for you in the next few minutes. So there are two kinds of twins. The twins that come from a single egg and the twins that come from a multiple egg. Monozygotic twins come from a single egg that divides. Dizygotic twins come from 2 egg and 2 sperm. If you have a pregnancy where the twin comes from 1 egg, the type of pregnancy depends on how early the egg divides. So if the egg divides very early, you get what's called a dichorionic diamniotic pregnancy. There's 2 sacs around the baby, the amnion and the chorion. This, for all intents and purposes, looks the same as a 2-egg pregnancy. You can't tell the difference on ultrasound, you can't tell the difference when they're born, and you can only diagnose the difference between identical or monozygotic twins or dichorionic diamniotic fraternal twins by either having different sexes or by doing genetic analysis. And so that's why you can't always tell if the babies are identical when they're born. If they divide a little later, you only get 1 amnion and, 1 chorion and 2 amnions. Those are so-called monochorionic diamniotic, and I'm going to talk about their problems. If they divide even a little later, you have only 1 sac and the babies are both swimming around in the same sac. And if they wait 2 weeks to divide, that's when you have the babies that are conjoined or joined together. The early division, the monochorionic diamniotic twins, have this thing called the twin-to-twin transfusion syndrome, which means that one baby, and about 1 out of every 6 times, gives the other baby some of his or her blood. And that creates a whole set of potential complications, which we now are developing in utero therapies for. If the babies are in the same sac, they swim around and they move around. And guess what they do? They tangle their umbilical cords up. And unfortunately, once they get past 32 weeks, more often than we would like to have happen, they sometimes knot the cords and suddenly get in trouble. And so these pregnancies are monitored very, very, very closely now, oftentimes in the hospital for weeks and weeks and even months. And finally, this is a conjoined twin flower. Can oftentimes be beautiful. And we, as I'm sure you've read in the papers in the past, sometimes these babies are born in the condition that we can get them to the children's hospital and in absolutely heroic operations, physicians, pediatric surgeons can divide the babies and get normal outcomes and life expectancies from these children. But along the way, the more and more attention we paid to the babies, the more and more cesarean sections we did, trying to achieve optimal pregnancy outcomes. Christine and I will talk about where we are now and where we're going, the sort of good, the bad, and the ugly. So thank you for your attention.
All right, so I'm going to talk a little bit now about what we've been able to accomplish that's sort of brave new world-like, some of the real advances, and then I'm going to end my section of it with where I think we really need to focus more of our attention, because some of these advances are amazing, but we have so much more work to do. So first I'm going to talk a little bit about fetal therapies, fetal surgery, a so-called exit procedure, and then I'll talk a little bit about a heart-lung bypass machine called ECMO that we use. I'm not going to talk about the new drugs, but there are many, and these are just a few of them that we use for various conditions that previously were not amenable to treatment. So I'm going to talk a little bit about some of the advances in fetal surgeries. Tom mentioned this a little bit. We've not been able to say, gosh, now we can fix this problem completely, no problems, but there have been some major, major advances. And this is really very high tech and involves multidisciplinary teams. So this is probably the way most people kind of envision a cesarean section, a baby nicely sort of lifted out of the uterus. Any of you who have had one know that this is hardly the way it is. But if you just sort of imagine it like this, and then you imagine that the baby has a problem. Let's say the baby is born with a great big tumor in the neck or in the mouth. And you can find that out, like Tom was saying, by ultrasound. You know that the baby is going to come out with this great big tumor at the mouth or on the neck. And because of that tumor, you can predict that that baby is not going to be able to breathe. It's going to try to breathe, but will not be able to get past this obstruction and get air down the windpipe. So what if you could then take the baby out partway and have your ear, nose, and throat doc, somebody come and put in a tracheostomy before you even deliver the baby. So you just take out the head or the neck and so forth. The mother's there, it's a cesarean section. There's tons of people in the room. We do this here at University of Washington Medical Center, and we've saved several babies just this past year. It's a so-called exit procedure. You can also do, surgery for defects that are expected to actually either cause death just because of delivery, or actually the baby dies in utero. This is one of those. This is called a sacrococcygeal teratoma. This is a fetus. It's a premature fetus. This is the mother's abdomen right here. This is the baby's umbilical cord. Here's the leg and a foot. And this is the tumor off the baby's back. It's a huge tumor. It's not a cancerous tumor, but it's filled with blood vessels. And it's very likely, you can already see here areas that are very thin, and it's likely to rupture either at the time of delivery or in utero. So this fetus is having this removed in utero, and then it's going back in, and it's going to gestate, and then get delivered. Isn't that amazing? So anyway, so there are merely miracles that are happening. There are a lot of other things that fetal surgery is being tried for. We've not been able to find that one that, gosh, this is going to make all the difference. But people are looking at things like spina bifida and this diaphragmatic hernias and things like that. The next thing that's really been a huge advance is this, what I call a heart-lung machine, or ECMO, extracorporeal membrane oxygenation for short. This is as though you and I were having open heart surgery and they put us on one of those heart-lung machines so that the surgeons could stop our heart, fix it, do whatever they needed, and all our blood is going through a machine, it's getting oxygen, it's carbon dioxide's getting removed, and it comes back in. Well, if we're in the operating room, that's just going to be for a few hours, right? And then we come off the machine and we get sewn up and we're done. But babies have problems around the time of delivery. These are term babies where they can't breathe, their blood vessels haven't opened up yet in their lungs adequately, or they've really been in big trouble at the time of birth, sometimes with infections and so forth. And they're going to need to have several days of this kind of therapy so that they can get over their condition and then get back on with actually being reborn in a way. So what this involves is actually putting great big catheters. This is the schematic of a baby's heart. And here's the big aorta, the red blood vessel that comes out of the heart, delivering all that nice red blood to the body. And you put a catheter in there, and then you put one in the jugular vein that is going to collect the blue blood from the right side of the baby's heart. And it goes into this circuit, and it gets oxygen, the blue blood, in this membrane oxygenator. It's like creating the placenta all over again. And then it goes through this pressure monitor. It gets all warmed up. This pump keeps it moving. And it goes back into the baby and shoots out just like the aorta does. You can actually stop the baby's heart, and the baby can live on this machine. We've had a baby on for 6 weeks on this machine while everything was getting better. So this has been a huge advance for some term babies. This is what it looks like. Again, it's always hard in my pictures to see the baby. There's the baby's head right there. This is a teddy bear right there. And you see, here's a nice window here. This is at Children's Hospital. Big team of people here. Here's that ECMO circuit. These are those cannulas that are going into the baby's neck. Here's the baby's neck right here. Again, imagine how this is for parents. We have to spend so much time walking parents through. Our nursing staff are so wonderful with the parents, helping them to say, okay, that's what this is, talk to your baby and all this sort of thing. The babies don't really feel anything when they're on this. We don't want them to move a whole lot because we don't want these big catheters to come out of the neck. So this has been a huge advance. Some others, we cool the babies' brains now. We cool babies when they've been really significantly depressed and have a real risk of brain damage around the time of birth or sometimes for other reasons. We've got better infection control measures, and we still need to be better still. We have much better infant ventilators that don't harm the lung. Joanne mentioned about my work with neonatal pain management, morphine, stress. We'd like not to have to use any of these drugs and actually be able to make a less stressful environment. That involves a much nicer looking NICU than that earlier one that I showed you. Family-centered care. Parents never used to be in the NICU. They came, delivered the baby, and picked the baby up. That was about it. Sometimes would come in, there were visiting hours, they never rounded with us. That's all changed. Parents are there all the time, and they're part of the care team. Kangaroo care. I love kangaroo care. So what is that? Well, so this is a premature baby on his or her mother's or father's, I think it's a father, chest, skin to skin. We have babies on ventilators who are held by their parents like this for hours. They grow better, they have better survival rates, and in foreign countries, in some countries where they don't have all the high-tech stuff that we have, this is what mothers do 24/7. They're the incubator, and the baby is held tightly to their chest. And it is an incredible experience for our families, both father and mother, to be able to hold and nurture their babies, because you feel so helpless when you have a baby in the NICU. So we do kangaroo care all the time now, and it's our nursing staff who've really championed this, where the doctors would be like, oh no, you can't do that. Yes, we can, and they do, and they're wonderful. So what's in the future? Improved therapies for premature lungs, no more ventilators, vaccines for infection, preventing bowel disorders, neuroprotection, all sorts of things. Prevention of prematurity, that's where I want to go. What about an artificial womb? So here is a premature goat, a fetal goat, in an artificial womb. Okay, remember those ECMO catheters? Well, those are in this fetal goat's belly button. If this fetus was delivered now, right from the mother, the fetus would die of RDS. But here's a tank. So it's like amniotic fluid. Here's, I don't know if you guys can make it out here. Here's the little ear, here's the little mouth, the eye over here, floats around, kicks around. The difficulty, and it's weeks, and then you can deliver it, and it runs to its mother and starts suckling. It's a long way from that, though, in humans, and part of the big problem for any nutritionists in the audience, how do we feed these fetuses? Because with all of our high-tech hyperalimentation solutions and so forth, we're not as good as the mother. And the fetus, sucks out calcium and all these things from the mother. That can't happen here. So we have a ways to go, but the fetus doesn't have to breathe. It's in there, in the tank. Our NICUs. Here, we're going to be building a big new NICU here. So 50-bed NICU. We currently have a 36-bed NICU, and it's packed. So We want single rooms, not those big NICUs with 12 kids in one room that we had before. Less noise, less bright lights, family-centered care approach. Our nursing staff and some of our industry folks work on making our NICU a more humane place to be and one that's not so frightening for parents. This is a very common problem. This is a jaundiced preemie. Preemies, their liver is not mature, so they get jaundiced. And then they get treated with phototherapy, so they don't get brain damaged from the significant amount of jaundice they can build up. And they need eye protection. It's like being out at the beach, you know. You don't want to be looking up in the sun. This is actually really scary for parents. And you can't see the baby's eyes. And there they are. And it looks weird. And so I just love this. So here's what somebody did. We use these now at Children's. Isn't this just great? So there it's like the babies, you know, everybody laughs, alleviating parental concern while effectively protecting the eyes during phototherapy. We work with industry to try to make some of these things, and these were actually created by one of our nurses. So old NICU, this is Children's Hospital, old NICU. I mean, look at this, you know. This is what the new NICU is going to look like here, these kinds of rooms. This is one baby's room, and then you've got one for twins or triplets, a window, all sorts of things. This is our rooms now at Children's Hospital, single parent, single windows. It's just wonderful. Okay, back to this. I'm going to end with this on my section. Okay, remember how we were all feeling so good about 6.5 deaths per 1,000 live births, infant mortality in the US. Our world rank, 29th. We're tied with Slovakia and Poland. Number 1 is Singapore. Number 4, Sweden. What do babies die from? It's prematurity. Prematurity, prematurity. And then you've got your infections, birth-related problems, and birth defect syndromes. It's worldwide. If you lump together infections, including tetanus, which is a huge problem in some parts of the world because of how they treat the umbilical cord, big packs of mud and things like that spread tetanus, and there's not so much immunization there. If you lump all of those together, infections account for 36% of neonatal deaths. But prematurity by itself, 28%. So it's a huge problem. The low birth weight is rising in the US. Tom's going to talk a little bit about this. So we have all this high-tech stuff, and we've saved so many babies. We can save babies this small. This baby weighed 280 grams at birth. That's less than a pound, and survived. How low can you go? At 26 weeks, 20 years ago, 80 to 90% of premature babies died. Now 80 to 90% survive. When you go down to 22 weeks, remember 40 weeks is your due date. Less than 10% survive. 23 weeks, 25 to 50% survive, if you do everything and they're delivered at tertiary centers. So how do they do when they survive? Well, the outcomes, which are not up to date, right? I know how many babies died here last year. But what I can't tell you is how they're all, the ones that survived, what they're going to be like at age 5. Because they have to get to B5. And then I need a lot of them, so I can say how they all do as a group. But for example, and this is what we generally tell parents, that 50%, if 50% of 24-week gestation preemies survive, then about 50% of the survivors will survive without major disabilities. And what are those disabilities? Mental retardation, inability to walk, cerebral palsy, blindness, deafness, and then your minor disabilities, your learning disabilities, behavioral issues, which of course, how do you know whether those are going to be problems even if you had a term baby? Tom.
So Christine has ended with some of the dilemmas that we face in neonatal medicine, and I'm going to talk about some of the dilemmas that perinatal medicine, the unintended consequences of our more and more acute focus on trying to make sure that the babies are born well and without damage. And that will revolve around prematurity, talk about cesarean section. You probably heard about a lot about that. We're going to talk about changing patient expectations of how often or how infrequently people expect to have something go wrong. And then we're going to use, Christine just showed you, we now operate in very complex medical environments, and they present a unique set of challenges for us to try to keep things safe. So this is the premature birth rate in the state of Washington, and you can see that starting in 1990, it went up, and that was 2006, and it's about 12%. There's been almost a 40% increase in the premature birth rate. And there are a bunch of things that we know about that cause prematurity. I told you about the perinatal paradigm. I don't think there's any doubt in many of our minds that some of the rise in preterm birth rate is related to people like me delivering babies prematurely to keep them from dying in utero. In the last few decades, there's been a significant decrease in the stillborn rate. That is undoubtedly due to our premature delivery of some babies so that they don't die in utero. But by the same token, we've increased the premature birth rate, and we may have swung a little too far. There are other reasons for prematurity, one of which I'm going to talk about right now, since it's on everybody's, or at least a few months ago was, and this is a picture of an ultrasound with a uterus with 5 babies. This brings into mind the octomom. What has happened here? Well, when I finished my residency in obstetrics and gynecology, test tube babies were like Buck Rogers. They were a pipe dream. They had never happened. Fast forward 30 years, it's like industrial production. There are lots of centers that do it. Unfortunately, one of the reasons that made it so successful early on was the introduction of more than one fertilized egg into the uterus with in vitro fertilization, because it increased the pregnancy rates. And since each cycle cost about $10,000, people didn't want to have to do multiple cycles to get one pregnancy. So multiple embryos were placed back in the uterus, and periodically you got surprised. Here is the rise in twins from 1980 to 2002. You can see almost a 50% rise. Even more dramatic is the rise in higher order multiples, triplets and beyond, from here about 2,000 or less than 2,000 to almost 6,000. And what's the problem with that? Well, think of the uterus as a one-bedroom condo. It only has room for one baby. And the more babies you put in there, the more problems you get. And so the gestational age goes down, the more babies that are in utero, and Christine just showed you that more prematurity leads to all of these handicaps. And the other problem is that besides prematurity, which occurs in 60% of twin pregnancies and nearly all higher order multiples, there is a higher rate of birth defects. There's a higher rate of premature placental separation umbilical cord accidents. The mothers have a 1 in 4 chance of developing preeclampsia, this high blood pressure pregnancy. The cesarean section rate for twin pregnancies is 60%. There is an increased risk of birth trauma and an increased risk of growth restriction. But I wasn't the first guy to figure this out. The first guy to figure this out was Mark Twain, and he said, "Sufficient unto the day is one baby. As long as you're in your right mind, you don't ever pray for twins. Twins amount to a permanent riot. And there ain't any real difference between triplets and an insurrection." And this 1879, Mark Twain had this figured out. So we have a ways to go here in modern obstetrics and in reproductive medicine to try to decrease this multiple gestation rate from special fertility. It's been a miracle. Like I said, it was Buck Rogers' talk in 1977, and now it's very common. And this is again a common slide. So along the way, as we paid more and more attention to babies in utero, we started doing more and more cesarean sections. And right now, the cesarean section rate in the United States is over 30%. Now, there are some people that would lead you to believe that this is avaricious physicians that are trying to do more cesarean sections to make more money, that we're doing this because people are afraid. But here are the things that have driven up the cesarean section rate. All of these conditions are known to increase the cesarean section rate. Maternal age. There is a direct line. When I got to the state of Washington, I looked up the basic data, and the cesarean section rate goes up in a woman who's pregnant every year from 16 to as far as you can get pregnant. And as more and more older women got pregnant, the cesarean section rate went up. Multiple gestations, I already told you, cause more cesarean sections. Diabetes, patients with diabetes have a much higher cesarean section rate for a number of reasons, and as you know, the rate of diabetes in women and in the population has gone up. Obesity has its own set, even if you aren't diabetic. That increases the cesarean section rate. When you're born preterm, you have a higher rate of cesarean section because the babies, when they're preterm, don't get oriented head down. They often come feet first. That sets its own set of problems, and so most babies born feet first are born by cesarean section. And finally, for a while, we were trying to do vaginal birth after C-sections in all settings. It can be a very safe delivery method in some settings, and it can be quite hazardous in others. And then finally, patient autonomy. Some women feel that they don't want to have vaginal birth. They want to have C-section for a variety of reasons, and we are not yet to the point where we simply deny that desire. That isn't a huge number of patients, but it is growing. And finally, people would make you think that this is about liability fears. But my feel about this is that there are very few doctors who do cesarean sections because they're afraid they'll get sued. They do cesarean sections because they're trying to do the best they can for the expectations of the parents. And this was brought home to me by a woman advocate in a birth defects symposium who said to me, you know, Dr. Benedetti, I know when you get up every day that you don't look in the mirror and say, I wonder how many babies I can hurt today. And what we usually say to ourselves is, how many babies can we help? And oftentimes that leads to cesarean section because the patient expectations are that every baby should be born without problems. So we're going to get to the clicker in a minute, but I'm curious to the audience and what your expectations are. This is what I call a challenger event. Actually, my colleague, Dr. Tom Easterling, came up with this word, and that is an unanticipated, catastrophic event resulting in permanent death or disability. So I'm going to ask you, what would you consider an acceptable risk that might be avoidable for a challenger event to occur during a labor? 1 in 1,000, 1 in 100, 1 in 10,000, 1 in 100,000, or 1 in a million. So you got 5 things. Let's get your clickers out and go ahead and click. A quarter, talk about 1 in a million. A quarter, say 1 in 100,000. And about a quarter, or 1 in 10,000, which the others, 1 in 1,000 or 1 in 100. So to help put this in a little perspective, I put this slide together. And this slide shows the chance that somebody will die in any given day. I never thought about this a lot, but so, you know, I'm a little over 60. My chance of dying tomorrow is probably about 1 in 30,000. When I was 5, my chance of dying was 1 in 2 million. And when I'm 85, my chance of dying in any given day is about 1 in 2,500. In 1960, my chance of dying during labor, intrapartum, was 1 in 1,000. Many of the things that we've done to make childbirth safer has reduced that now to about 1 in 10,000, or about 1 in 5 to 10,000. But pregnancy, the day you're born, is usually the most dangerous day of your life. And most of you said that you would like to have that avoidable risk to be 1 in 100,000 to 1 in a million. The only way to achieve that level of safety and protection is to do cesarean sections on everybody at 39 weeks. Your chance of dying in labor is 1 in 5,000. Your chance of stillborn waiting from 39 to 40 weeks is about 1 in 1,000. And so bad things happen, and people are starting to understand this and appreciate this. And most mothers, when you start to present risks and benefits, will say, I'll take the risks myself. I don't want to take any risk for my baby. And that's the social environment that we're now moving in obstetrics and gynecology. And that is one of the main reasons why the cesarean section rate is rising, in my opinion. And finally, we're in a really complex medical environment. Christine just showed you all those machines. I showed you our machines. The safety data and the safety people in medicine now talk about errors in medicine because of complexity as being like Swiss cheese, that to stick the prod or shoot the bullet through the cheese, you have to hit all the holes in just the right angle. And this doctor talked about moving towards patient safety in obstetrics as getting to Havarti. In other words, the solid cheese rather than the cheese with all the holes. And what do we need to do to get there? Well, we need to have, as Dr. Atul Gawande said, a much more rigorous form of regimented care in medicine and obstetrics in particular. That is checklists. And I'm proud to show you this checklist because this is our checklist that we developed in the late 90s to treat emergency hemorrhage in obstetrics. And we have reviewed this every year, made it better and better, but you can see it has a tree. And these things happen automatically when somebody starts to bleed. Everybody knows what to do. There's no judgment involved here. The checklist says do this, we do that. That's a pretty hard sell for most doctors. Most of us are pretty independent. Most of us like to think of ourselves being a little creative, but in emergencies, being creative is not where you want to go. Everybody recognizes this picture. What most people don't realize is that one of the main reasons this plane is like this and still floating, besides Mr. Sullenberger being a great pilot, was what his co-pilot was doing. And while this plane, as soon as they hit those birds, Sully Sullenberger said, "My plane," because the co-pilot was flying the plane. And when he took the plane, the co-pilot got out the ditching checklist. And he started going through all of the things that he had to do to prepare the plane to ditch. And the reason the tail is down is because one of the last things on the checklist that he didn't get to was closing those back exit doors. And so they started to take water, and that's where the water came out. Otherwise, the plane would be upright. So we need to get there in medicine. We'll get there in obstetrics. I think we'll get there in medicine, but we have a long ways to go. And so I'll end with my other favorite quote, Will Rogers. It ain't so much what we don't know that gets us into trouble as what we know that ain't so. And the other way to say that is what has been called the professor's lament. Half of what we taught you tonight is wrong, but unfortunately, we don't know which half. Thank you very much. So, in the interest of time, your final exam, which is in there, has all the answers anyway, so it was a dry lab final exam. So Christine and I will be happy to take questions for the next 10 or 15 minutes. Please approach a mic and ask away.
You've been talking about all the successes, but, and maybe this is an ethical question too, about playing God in the nursery, particularly with birth defects, and how do you make decisions there, and also taking into account what it means to the family in terms of dealing with severe deformities and so on up.
It's a very, very important question, and one that I'm really proud of where we've come in our field to not only have family-centered care be part of this. Parental autonomy is very much considered in making decisions, but I think that end-of-life issues and where you know, it's no longer like it was in the old days where no matter what you did, babies would die. There are sometimes, I think, people feel there are things that can be worse than death for the baby if it's going to be a lot of pain and suffering. And we talk to each other, and we talk to our parents, and we get advice. We have palliative care teams, we have end-of-life teams, ethical issues, ethics committees, when there's disagreements. But I think the important thing is that there's no one right answer for this baby or this condition or that defect or whatever. And what we do as neonatologists is do absolutely everything we can that's in the best interests of the baby. And we hope that all of those, you know, that sometimes doesn't mean pressing on and doing absolutely everything just because we can. So we're there for the baby, but it's a team approach that thankfully these days does involve at great expense to them in many ways, but thankfully it involves the parents in making those decisions.
Yes, ma'am.
I was just curious, I was looking at the infant mortality rates compared to the US compared to the world rank, and I was just curious why the US was relatively lower on the list as compared to other countries like Singapore and Sweden.
Well, that is a very complex question, but and it gets into a lot of politics. So one that's not real political has to do with the heterogeneity or the homogeneity of the population. Many of the countries that have the lowest rates have very homogeneous populations. That is, they don't have the mixing pot that we like to think of ourselves in the United States. But the thing that probably totally dwarfs that is most of those countries have very appropriate and well-run healthcare systems. And we're still struggling in the United States to convince ourselves that healthcare is a right rather than a purchased commodity. And because of that, we have these very uneven outcomes. Probably the neonatal survival in the United States for these very small babies is the best in the world. But the conditions that lead to these babies being born, the premature birth rates and all the other things, are much higher than the rest of the. Those are not medical things for the most part. Those are societal, societal choices, if you will, that individuals don't make, but that the society has.
Thank
you. Is there an OB protocol for when to do an emergency C-section when a woman is in labor, lengthy labor?
Excuse me, what kind of a protocol? Or
An OB?
An OB. Well, the decision to do an emergency cesarean section can be related to many things. Bleeding is one. More commonly, an emergency cesarean section is related to some suspected or proven fetal compromise, when the heart rate goes to a very low rate and you're afraid if you don't deliver the baby, it's going to die. Unfortunately, that fetal monitor that I showed you has a high false positive rate. Sometimes Things look really bad, but they're not as bad as they look. And the last 10 or 12 years has been spent trying to augment the interpretation of fetal heart rate monitoring so that we can have a better test. Unfortunately, those other tests have not panned out very well. So we're still left with that. And there are undoubtedly more cesarean sections done than are probably needed, but trying to sort out which ones are needed to be done and which ones are not is proving to be very challenging. And that's because, as you all showed us, the societal tolerance for bad things happening is a very, very small number. When I got in this business in the late 70s, that number, which we would sort of tolerate for bad things happening, was 1 in 100. That tolerance now in the medical profession is about 1 in 1,000 to 1 in 2,000. And what the audience just showed me is that their tolerance for that is 1 in 10,000 to 1 in 100,000. And so we've got a real disconnect here because you have to do a lot of things to people that might not need them in order to make sure that you don't miss that 1 in 100,000. And that's the dilemma we've got.
Is the decrease in those operative vaginal deliveries perhaps also due to the fact that you're not getting as much practice? It's such a subtle art. I mean, is it because you're not doing it often enough to really feel confident in that approach, and you kind of get skewed towards cesarean route?
The actual number of spontaneous vaginal births has been fairly constant, about 2/3. And my old mentor, when I was a student, Joe Sychek in San Antonio, Texas, said to me a very profound thing. He said, "You know, Tom, about 2/3 of women don't need any help at all having a baby in terms of advanced skills. About 1/3 do." And when he told me that, the cesarean section rate was about 5 to 7%, and the forceps rate was about 20 to 25%. Now, the cesarean section rate is about 30%, and the forceps rate is about 5%. And you're exactly right. Some of that has been due to concern for fetal injury with operative vaginal deliveries, but it's a positive, what we call a positive feedback loop, is the less you do, the less skills you have, the more uncomfortable you are doing something that you don't do very often. And one of the ways that we're hoping to address that is in the simulation center, where we can develop models to get people to have skills so that they feel more and more comfortable about doing this. Class dismissed.